Hello, welcome to our second day of Knee Notes. As you can hear, actually we have some music going today. Somebody came over to say hello.
Free world is going on. Sports Med, get to class. Some of you are still walking down that 400 hallway tardy. Go ahead and grab your breakfast. I've got mine right here. I've got a cold Coke right here. And candy for correct answers if Coach Soren has any trash can basketball or anything for the Sports Med. All right, it's M&M Monday. Don't be afraid.
All right, thanks, Coach K. We'll talk to you later. All right, so we have a little Coach K welcome this morning. All right, we're going to start out with a review of what we did yesterday. All right, the anatomy of the knee. There are 4 bones that make up the knee joint: the femur, the tibia, the fibula, and the patella. We talked about the different joints within that, the different parts of the joint. We have the tibiofemoral joint, which is the tibia and the femur. We also have the patellofemoral joint, which is the patella rides in the trochlear groove of the femur. And then one that we didn't talk about was the tibia and the fibula of the joint, which is right here. With anatomy, continuing, we talked about the medial and lateral meniscus. We talked about, talk about tears, the medial and lateral meniscus. Talked about the MCL being the medial collateral ligament that runs on the inside of the knee here, and the lateral collateral ligament that runs on the outside of the knee. We talked about the anterior cruciate ligament, or the ACL, and the posterior cruciate ligament, the PCL. The muscles that we talked about, the group of 4 muscles, the quadriceps, and then the hamstrings in addition to that. Injuries to the knee. I have a little bit of experience with knee injuries that I have shared some in the lessons, or I will be sharing some. We talked about O'Donoghue's, the terrible triad being a torn meniscus, torn MCL, and torn ACL. The MCL sprain, we spoke of that last week. That's on the inside or the middle of the knee. Talked about some tests. The valgus stress test will test for an MCL sprain or tear. Meniscus tear. There are red flags: swelling, pain, popping, locking. There's 2 different tests we talked about yesterday. The Thessaly test and the McMurray test are both tests for torn meniscus. Different types of meniscus tears. I have some pictures. This is a bucket handle tear. This is from a scope, what a meniscus tear would look like. This is a shredded meniscus right here. And here's the meniscus here, should be smooth along there as well. The anterior and posterior root tears. So if meniscus tears out from the root here in the anterior portion or here on the posterior portion, it allows the meniscus to slide out of the joint or to extrude. This is what it looks like when there's high-grade extrusion of the medial meniscus has slid out of the joint there. This can lead to rapid developments of articular cartilage damage of the femur and tibia, which we will talk about later. There's meniscus tear. There's some treatment options for meniscus tear. There's a meniscus tear repair. There's a meniscectomy where they take it out or part of it out, and a meniscus transplant. A meniscus transplant, I believe this is where we left off yesterday, where the meniscus of a cadaver is taken from their knee, and then there's 2 bone plugs left on. If it's a lateral transplant, they use a trough, which they leave a whole bone piece there, and then sometimes they don't leave any bone pieces at all. This is a salvage procedure for patients that are too young and too active to get a knee replacement. Concomitant procedures are very common with meniscus transplant. Some pictures from in the surgery. This is scope pictures of what a meniscus transplant looks like. It's sewn in there, the meniscus. This is a meniscus of a cadaver before it's placed in somebody else's knee joint. Another picture, these are all pictures of the meniscus transplant once it is sewn into the new. So this was sewn into the tibia. All right, I believe this is new notes for today. So we'll talk about ACL tears and the mechanism of injury. Anterior cruciate ligament tears. Most of the time, 70% of the time, this is a non-contact injury where somebody plants and turns or pivots on one leg with one leg. The leg that is plant and turn on is the leg that is torn, the knee that's torn. This often occurs in sports such as basketball, soccer, American football, volleyball. Think of any sport, skiing, lacrosse, tennis, where you are constantly changing directions and moving from side to side. This can also, an ACL tear can also happen whenever there is a blow to the outside of the leg. Mechanism of injury, again, is just plant and turn, which we do in most sports that we play. We do it thousands and thousands of times, and it's not an issue. However, one time it could be an issue. Who is at risk? Really, anyone playing a sport that requires quick changes of direction. Increased fatigue. So at the end of your workout, towards the end of a game, I know the day that I tore my ACL, I had already run, I'd already lifted, and then I played soccer. In the last 10 minutes of our soccer practice is when I tore my ACL. So I believe that fatigue was a part of that. An increased posterior tibial slope, or PTS, and then women are at greater risk than men. So we'll look more closely at a couple of those things. And injuries to females are 8 times more likely, or females are 8 times more likely to tear their ACLs than men. Why are females more prone to the ACL tears? Well, there's some different philosophies and different theories. We really don't know for sure. Some of those things might be hormones. They have a wider hip, so they have an increased Q angle, which we'll look at in a little bit. Decreased intercondylar notch, and that's where the ACL runs through the knee joint. The strength of the hamstring. Females may have a decreased hamstring strength, which puts more stress on the ACL. And then biomechanics. Females stay higher when landing oftentimes. They don't land in that bent knee stance that we really need to work on to prevent ACL tears. Right, here we have a decreased intercondylar notch. So this is the intercondylar notch now, and you can see that they're measuring on this one, on this x-ray. This one looks like 23 millimeters. So it decreased intercondylar notch, so a smaller intercondylar notch that runs through here. The ACL runs from here to here. This is posterior tibial slope, so you can see the tibia here. The greater the posterior tibial slope, they think the increased risk of tearing your ACL in sporting athletic activities. Symptoms of an ACL tear. Oftentimes you will feel and maybe hear a pop when the injury happens. There's going to be most likely immediate swelling of the injury. There may be a deep pain in the knee. You just don't know what's wrong. You know something's wrong. Oftentimes instability. The knee just kind of gives out. When I tore my ACL, I felt like a baby giraffe that was just born and trying to walk. There's no stability there whatsoever, because remember, your anterior cruciate ligaments attach bones to bones. So whenever that ACL, which is a big stabilizer, whenever that is torn, you don't have that stability. Kind of feels like your leg is just kind of hanging there. There will be a restricted range of motion with particular difficulty straightening the affected knee. The knee may feel warm to the touch. This is due to the swelling, the blood flow to that area. Oftentimes an athlete, and I was looking down at the soccer ball whenever I hurt my knee, and I saw my tibia shift on my femur to the inside like this. So oftentimes you will have an athlete say they felt this shift. Mr. Snow says that's a universal sign for tearing your ACL is showing this shift like that. Testing and diagnosis. First thing, whenever you go to the doctors, whether you go to an orthopedics office, your family physician's office, they're going to do x-rays. The first thing they want to look at is to see if there's anything that has been fractured, any of the bones, the patella, the femur, the tibia, the fibula. If anything's been fractured, they will check that out first. The second thing they'll do, they're going to send you off to someplace else to get an MRI done in the next 3 days or so. Once the MRI results come back, as you can see, there's some results here from what they would look like from an MRI. There's another thing they can do. This picture here is showing where they're injecting dye, and they're going to do a contrast MRI, so they still do the same MRI, but you can see things more clearly. You can see here there's complete rupture of the mid portion of ACL. There's an impaction fracture of the lateral femoral condyle and the tibial plateau. They call that a pivot shift injury. Contusions, which are bruises, and they're finding that these contusions are a bigger deal than they originally thought. A contusion may lead to long-term damage. And this was to the medial tibial plateau, which I have continued to have trouble with years after my injury. An MCL sprain, so you can see I had the O'Donoghue's terrible triad with a meniscus, ACL, and MCL. Here's the meniscus. There's a couple of tears on the meniscus. So that's what an MRI result would look like. Ruptured ACL versus a non-functional or just a lax ACL with laxity. And these are both scopes. This was from an ACL surgery. This is my ACL that has torn completely. You can see it's kind of just bunched up there. And this is, after my ACL, this is my second ACL. This is reconstruction of patellar tendon. And this is a lax or non-functional ACL. And you can see how it's kind of wavy here. You want it to be very tight. And I believe we'll see in pictures in the future here what an ACL should look like. So they could move this and it wouldn't actually move the knee. Here's our pictures. All right, so ACL repair. There's a couple ways that they can do this. They can do this with an internal brace, and you can see the internal brace here. My second ACL revision had this pictures from that, an internal brace, which is just a cord attached in that ACL to give it more strength. This is a hamstring autograft. This was my original ACL revision. There was not a internal brace in that one, and you can see that this is kind of a mangled ACL, but not completely torn. That would just have laxity. ACL testing. There's a couple of ways that they can test. There's slide test and there's pivot test. The first one are slide test, and the slide test are Lockman test and the anterior drawer test. And this is testing for ACL function. You can see here, when they do these slide tests, they're seeing if the tibia slides anteriorly on the femur. Here's a picture or video. And you can see the tibia sliding forward or anteriorly on the femur in this short video. It's a lax ACL. It is not completely torn. ACL testing. First, we're going to look at the Lockman test. The Lockman test is a slide test.
This is going to be the Lachman test to test for anterior cruciate ligament rupture.
So when he's actually doing a test.
In supine-like position, and bring your patient's test leg into 30 degrees of flexion. Fixate the femur with your outer hand, bring the tibia into slight external rotation, and then try to translate the tibia anteriorly.
So he's trying to pull the tibia forward.
This test is positive if you experience a soft or mushy end feel, or if the anterior translation of the tibia in the injured leg is at least 3 millimeters greater compared to the uninjured leg. Please keep in mind that your test results in a chronic situation.
When you first see the athletic trainer, they're always going to start with your uninjured leg. And so they'll do the Lockman test on the uninjured leg, and then they'll go to the leg that has been injured. Let's see if I can move me so you guys can see this one. All right, this is the anterior drawer test. I wish we were in the training room.
This is going to be the anterior drawer test
to
test for ACL tears.
All right,
the anterior
drawer test.
Bring your patient's hip into 45 and your patient's knee into 90 degrees of flexion. You can fixate this position by gently sitting on the foot of your patient. Then palpate the joint line with your thumbs and try to move the tibia anteriorly in an explosive movement.
That guy doesn't have much give at all trying to pull that tibia
This test is
forward.
positive if the tibia translates anteriorly more than 6 millimeters or if you experience a soft and mushy end feel. This was our video on the anterior drawer test.
All right, I'm going to move back to the corner here, and we'll continue on. So those are the slide tests. The next thing are pivot test. Some examples here of what a pivot shift would look like. Oops. You can see how it shifts, it clunks. It's kind of inside to outside. And here's another picture. This one's going to be pretty small. This video is going to be small. Oh, guess we got to wait for the stuff to go away. You can see that shift right here, the tibia. This is anterior lateral instability. And we'll do a pivot shift test. Mr. Snow is probably not going to do a pivot shift test. If you go to the orthopedic surgeon, they're going to do the pivot shift test. It is more difficult because it's painful for the patient if you have this, if you have an ACL that is torn or if you have a chronic ACL laxity, this is something that hurts.
In this video, I'm going to show you how to
All right, here's a
supine-like
pivot shift
position
test for ACL.
with his hip both flexed and abducted to 30 degrees. Then grab your patient's calcaneus from the outside to induce tibial internal rotation. Some authors also describe added axial compression. Now with the other hand, you want to give a slight valgus force